Welcome to the Pharmacy Leaders Podcast with your host, Tony Guerra. The Pharmacy Leaders Podcast is a member of the Pharmacy Podcast Network, with interviews and advice on building your professional network, brand, and a purposeful second income from students, residents, and innovative professionals.
This is Sean P. Kane, Assistant Professor and Critical Care Clinical Pharmacist at Rosalind Franklin University, and you're listening to the Pharmacy Podcast.
Welcome to the Pharmacy Leaders Podcast. I've been doing this for about a month and a half now, and it looks like a Monday, Wednesday, Friday is when you can expect to see episodes. Maybe we'll have a bonus episode from here or there, but that's what it looks like we're going to have for the year. I was kind of checking my bandwidth to see how many episodes I could do in a week or in a month, and that seems to be good. But what I wanted to bring back was Dr. Sean Kane from Rosalind Franklin University, who maybe has taken the road that many of you are looking to take, which is to do PGY1 residency, PGY2 residency, and then get an academic position. I think he's really articulate in the way that he talks about how it worked out, and it's not always a completely straight line, but rather kind of a series of readjustments and decisions that eventually get you towards your goal. So please enjoy this episode with Sean Kane of Rosalind Franklin.
Today we're talking with Sean Kane, PharmD BCPS, an assistant professor at Rosalind Franklin University of Medicine and Science in North Chicago, Illinois, and a critical care pharmacist at Advocate Condell Medical Center in Libertyville, Illinois. Dr. Kane received his Doctor of Pharmacy degree at Butler University in 2010, completed 2 years of residency, specializing in critical care at the University of Illinois at Chicago. And Dr. Kane is the creator of ClinCalc.com, an evidence-based clinical decision support website with educational tools for healthcare students and professionals. In addition, Dr. Kane is the creator and co-host of HelixTalk, Rosalind Franklin University's College of Pharmacy podcast. Welcome to the Pharmacy Podcast.
Thanks for having me.
Well, we want to get right into it. I know about you because I've listened to your podcast from episode 1, the top 200 that you guys did, and follow every 3 weeks as you guys get the podcast out. But let's get our listeners to get to know a little bit about you. So, Dr. Kane, before we get started, what was your leadership road from Butler University in Indiana to Chicago as a PGY1 and PGY2 to your present academic position?
You know, I'd say when I was at Butler University, I kind of fell into some leadership roles. A lot of it came through professional organizations like Phi Delta Chi and through being a class officer. And kind of as I got more into it, the more interested I became in, being a better leader and improving myself and things like that. So at Butler, those experiences really helped me transition to going into PGY1 and a PGY2. Actually, it was when I was a PGY1, I started ClinCalc.com, which you mentioned earlier. And clearly that has a lot of things related to leadership and taking initiative and things like that. It was my goal to do something that people hadn't done before with that website. And then as PGY2, I was the chief resident, so I had a lot of kind of more administrative responsibilities. I got to see some of the other sides of pharmacy residency and what goes into conducting a residency and things like that. And then now at my current position, again at Rosalind Franklin University, I'm a co-host of HelixTalk. I serve on a lot of different committees within the college to improve the quality of education here at Rosalind Franklin University. And then obviously I precept, so I'm a critical care pharmacist. So certainly one of my roles is to serve as a good mentor and leader to the students that I precept at my clinical site.
Okay, well, tell me a little bit about this ClinCalc online, and maybe you can talk about PhomEd in general. My understanding is that stands for Free Open Access Medical Education, and what you're doing with your podcast, what you're doing with ClinCalc online is giving this information absolutely free to anyone that wants to use it, and that just seems to be something that's a bit of a trend on Twitter, on social media. So tell me a little bit more about what ClinCalc is, how it started, and maybe where it might be going.
So it's actually funny how ClinCalc started. As a PGY1 at UIC, we had an on-call program, which meant that we would stay overnight, have a pager, and get paged for everything from kinetics consults of vancomycin and aminoglycosides to antibiotic dosing, all the way to codes and strokes and things like that. So I actually created ClinCalc fairly selfishly because every time we got a vancomycin consult, it took a long time to do the math of how to dose vancomycin and then actually generate a progress note indicating that the pharmacist had reviewed the patient chart and what our recommendations were. So I actually created this website where it would semi-automate the process. I was still clearly involved in the decision-making process, but this was a tool to help make me more efficient. So from creating this vancomycin calculator and having it generate a progress note for me, I kept doing more and more of these clinical calculators that would just make my job easier, make me more efficient as a pharmacist, and help me provide better care for my patients. And of course, as an add-on to that, it was a publicly available free website and still is. So, any other clinicians that want to have the efficiency benefit and the benefit of utilizing, evidence-based medicine, they can use this website to leverage their own, clinical practice. So that's kind of what ClinCalc grew out of, was that PGY1 experience, and then it's kind of grown from there in a lot of different directions, from mobile apps to, beyond clinical calculators to, as you mentioned, kind of dabbling a little bit in FOAMed, where it's more of a review of, a primary literature article or something that, overall helps pharmacists provide better care for their patients.
So I think the term I've heard over and over again is scratch your own itch. That is, instead of telling other people what they need to do better, just make it a little bit easier for yourself, and that problem may be something that you're also solving for other people. For me, it was that I had students that had chemistry maybe 20 years ago or never even had chemistry, and I've got to teach them pharmacology as an 18-year-old, 19-year-old, and what do I do? So I kind of came from it from a humanities perspective. But first, scratching your own itch, kind of figuring out what it is what problem you need to solve for yourself. But I've also heard about IBM Watson. And can you talk a little bit about how technology, because I started pharmacy school in 93, finished in 97. The big thing was that we got laptops. So that was how long ago that was. The internet was just something fledgling. When we were coming out, we were still using Netscape Navigator. But how do students work with technology? Because I understand IBM Watson, we hear that it's not supposed to replace the clinician, but to work with the clinician to go through all of these databases and make things a lot easier. So how do students up at Rosalind Franklin work with technology as they're doing kind of these clinical activities?
You know what, Tony, I think you bring up such an important point in that the pharmacist will never be fully replaced by any degree of artificial intelligence or a database or anything like that. There's so much art to medicine that you just cannot replace, a living human being who has a skill set from being in pharmacy school and being trained and having clinical experience. There's always this fear that people have of things like online calculators that, if a calculator can do it, why do you need the pharmacist in the first place?
Sure. Mm-hmm.
I always tell my students and anyone who uses the website is that this is a tool for you to use. It doesn't replace you. So using vancomycin as an example, I always tell all of the students that I precept that you got to come up with a vancomycin dose on your own before you even begin using a tool like that. And the reason is that it takes one typo, one little mistake, that if you're not critically appraising what the dose is coming out of a clinical tool, you're going to make a drug error and hurt someone. So this is always a tool that is an adjunct to your own clinical judgment, and it's not the reverse where it is your clinical judgment. And that's such an important thing that I hope everyone takes away from that, is that you still have to use your own clinical thought process as opposed to just relying blindly on whatever the tool is.
Yeah, I've heard that over and over again, that it's about getting the process right, and the technology will magnify it in whatever direction. So if you have a bad process, you're going to magnify that bad process. But if you have a good process, you can magnify that good process as well, which just sounds like what you developed through PGY1, PGY2. But tell me a little bit about I just saw someone on Facebook today, very excited. I believe she's with a renal team, and she got that job after PGY1. But tell me what it is to go from a PGY1 to PGY2. Is that something that you had set up there, or you decided to stay in the same place, or did you look at other different places?
Yeah, so, for personal reasons, I wanted to stay in the Chicago area. And because of that, my options were fairly limited. As a PGY1 or a pre-PGY1, I did specifically look at programs that had a PGY2 critical care component with the intention of potentially having that door open to me if I was to match at a PGY1 spot. And then when I became a PGY1 and I was looking for PGY2 spots, obviously I was looking for, critical care in particular, and I was open to maybe emergency medicine as well, but critical care was really what got me excited and things like that. So I would say that for probably through my P2 or P3 year, I had a pretty good idea that I was going to end up pursuing a PGY1 and PGY2 in critical care, but it wasn't until I was really at my PGY1 spot that I really thought about the nuts and bolts of how that entire career path would work and how it worked out and things like that.
It was a little weird for me to hear you say when I was in the match, because when I think of the professors, I never really remember that. I'm like, oh my gosh, they all went through the match, or they had
right.
to go through the match too. You kind of, I don't know why, for whatever reason, I think, oh, they were so smart. You know what? They didn't even have to go through the match. They just called them up and said, hey, I'm your critical care guy.
Right.
Just take me. But I forget that, that happens as well. And looking at the faculty you have there, you have a relatively young group, which brings a lot of energy, brings a lot of new ideas. It sounds like you're trying a lot of new things. And when I say young, I mean, less than 10 years out. I've been out 20 years, which actually makes, I think, me a liability in many ways. That, it's like, well, and I'm sure they would be really polite about it, but let's say I went to a faculty interview now, they'd be sitting there, maybe asking like, so PowerPoint, Word, maybe looking to see if I know those basic things. But what do you think is different, because we're talking about Gen X maybe versus the millennials? What's maybe a couple of big differences you can tell me about your ability to connect with the millennials versus someone that is in a Gen X position like myself, or maybe even a boomer generation, something like that?
Yeah, I mean, well, first of all, in defense of you and all of the other
appreciate it
quote unquote older pharmacists out there, everyone's different, right? So you're going to get Gen Xers who are more like the millennial and vice versa. It's just a label, right?
Sure.
So with that in mind, though, I think that any newer graduate that you get is going to probably be able to relate to some of the topics and the struggles of being a student better than an older person would. And the reason that I say that is that so I graduated in 2010, it's now 2017, even over the past 2 to 3 years, I feel like I've become more disconnected in understanding the struggle of the pharmacy student, more disconnected in appreciating what they don't know and what I take for granted that they do know and things like that. So certainly with that younger faculty, they're going to have a better idea of what were common misconceptions, what are things that you have to delve into deeper, because it's not a given that a student would know about a certain topic. And I think that there's a huge strength to that in terms of how you teach a pharmacy student, because if you were there not that long ago and you know what it was like and you know what you struggled with, and there's intense value to that as an educator to remember that and to harness that into being a better teacher.
Yeah, I think a physicist coined that term, the curse of knowledge, where the further you get in your education, the less you're able to connect with those that were kind of following in your footsteps. So even a PGY1 or PGY2, so many things have just become ingrained. The renin-angiotensin-aldosterone system is one picture to you, where they're sitting there, struggling through angiotensinogen to angiotensin 1 to angiotensin 2, and so we have these kind of combinations. Well, let's make it a little more academic, I guess. We want to do a little bit of interview, but also kind of wanted to talk about this debate in the American Journal of Pharmaceutical Education. I want to make sure I get this right. So it was 2016, number 80, article 37. Okay, and there's a point counterpoint in there. Do you want to introduce our two sides of this point counterpoint, Dr. Cox and Dr. Svensson?
Yep. So Dr. Cox is of the Texas Tech College of Pharmacy, and then Dr. Svensson is from Purdue. And basically, the point counterpoint is fighting it out whether fourth-year pharmacy students or final-year pharmacy students, when they go on their advanced experiential education rotations, whether it's appropriate for those students to take an academic or an administrative type rotation and count that toward their API or advanced experiential education hours or not. The debate is basically, should all rotations in that fourth year be somewhat related to the medication use system, or given the ever-changing role of the pharmacist in the future, is it appropriate to consider some of these more novel or different rotation opportunities, even if those newer opportunities don't necessarily touch the medication use system?
I'm going to take a page out of the HelixTalk where one of your two co-hosts would say, well, Dr. Kane, what is the medication use system?
Yeah, I love it. So the medication use system is basically, and they have a great diagram in the article, but it's every aspect from drug development to prescribing, dispensing, administering, monitoring drug therapy, basically anything that touches drug therapy from beginning to end of drug development all the way to giving it to a patient. And that's the medication use system.
Great, we'll be right back.
But first, a word from our sponsor.
Hey, are you talking to Uncle Bob for financial advice? Are you prepared to begin taking charge to secure your financial future? Hi, this is Tim Baker, a certified financial planner and founder of Script Financial. Script Financial is a fee-only financial planning firm dedicated to helping pharmacists and young professionals meet their financial goals. Budgets, student loan repayment plans, saving for retirement, it's a lot to figure out by yourself. Script Financial is a fiduciary that puts your best interest first when taking the proper steps to secure your financial independence. Schedule a free consult by visiting scriptfinancial.com. Script Financial, the prescription to financial freedom. Now back to the Pharmacy Podcast.
Okay, well, let's kind of talk about these two types of rotation, the academic rotation, and we'll compare it to the critical care. Intuitively, I would think a rotation with a professor would actually be the most difficult because you have the person that's most knowledgeable about a specific set of maybe it's so knowledgeable as you go to PhD or PharmD or PGY2, you become very good at a very narrow spectrum. I hate to use an antibiotic term, but a very narrow spectrum of knowledge. But what the comparison was, or if I remember right, was versus the critical care, which you hear. So basically, you're the problem, or your rotation is the problem, is what they were saying, that you're taking the student from 6:30 a.m. to maybe 4:30, 5:30 p.m., where an academic rotation might be more of a 9 to 5. Could you characterize the two types of rotations as you see them, academic versus critical care?
Yeah, so clearly, like in a critical care environment, you're dealing directly with patients and you're dealing directly with medications. And, especially in the critical care environment, that's a very environment where patients are very sick. And, one of the reasons I love critical care is that there's such a huge role of the pharmacist because of things like organ dysfunction, and the medications that we use literally can save someone's life in a matter of minutes to hours. There's such a big role for that pharmacist to play to make sure that we're giving the right antibiotics or the right drugs, that we're dosing it appropriately. Things like renal impairment are so common. So it's a very complex picture. And typically in an ICU, you have a ton of patients who are really sick. It's not like you're just taking care of one person.
Sure.
On the academic side, you aren't taking care of patients. You're typically taking care of students, right? So you're figuring out how to run a lab or give a lecture or write exam questions. And it obviously isn't the same kind of stress, but for some students, public speaking is extremely stressful. So it depends on the student, but clearly the types of interaction a student's going to have, the responsibilities, things like that are just different between the two rotations.
Yeah, and you make a good point. Our academic APPE here at DMAC, they would be in front of pharmacy technician students. They would be able to interact with the other 19 programs we have here in Health and Public Services. But it's definitely not get up at 6:30 because I wouldn't be here. I get up early, to work out, but I don't really get here till 8, and that seems to be late. And then critical care, it just sounds like it's a very long thing. You've got all of these different patients, and I feel like I want to say getting up to speed for critical care, or if you're, I hate to say unlucky enough, but if you hit critical care as your very first APPE, or how do you call them, APPEs? So if you hit that first, do you feel that student is at a disadvantage? Do you think is there something they should be taking before the critical care rotation?
Yeah, I mean, to have a critical care rotation as your very first APPE or APPE, that's pretty brutal. From a scheduling point of view, generally it's nice for the student to have an inpatient medicine rotation under their belt, or at a very minimum, some kind of an internal medicine thing, just so that they can get their feet wet in terms of reading through progress notes. If you think about how many words you could potentially read per chart per day, it's insane. So
with the EHR, it's especially so with that copy and paste seems to be a bad word that we keep hearing with the EHR. And with your PGY1, PGY2, were you already familiar with the EHR and it made it easier for PGY2?
Oh, yeah. So, on my P4 rotations, most of the hospitals, or many of the hospitals I worked in, had Cerner, and at UIC we also had Cerner. And clearly, because I was at the same institution between my first year and my second year, my learning curve for Cerner was basically none. And then I was fortunate enough at my current site at Advocate Condell, we also have Cerner. So to be super familiar with the EHR and be able to get where you want to go and find the information you need quickly, that's a huge skill that makes you way more efficient than if you're kind of struggling through that software.
Sure. Okay. Well, let's talk a little bit about the points of view. So let's take Dr. Cox's point of view of saying that maybe an academic rotation isn't necessarily to become part of the academy, to become an assistant, associate, or full professor, but rather to be a good preceptor. I know that at the last meeting there was a lot of talk, and I think it was in Anaheim, that we really need more non-faculty preceptors out there volunteering to help these students. Tell me a little bit what you think about in terms of what the academic rotation can really do outside of just here you have to go to the academy.
I think that if you were to poll 100 preceptors or anyone who interacts with pharmacy students, the vast majority of them will have never received any formal teaching or precepting education to help them be a better preceptor. And that's, something that the world of pharmacy really needs to pay attention to, because these are the people who are training our pharmacy students to be pharmacists, right? So we want them to be able to, deal with issues that come up on advanced practice rotations. We want them to be able to identify when a student's struggling and, use their skill set to make that student successful. So in my opinion, precepting isn't something you can just fall into and you become a great preceptor. It takes time and energy, and certainly you'd be a better preceptor faster if you can have some kind of formal training, even if it is one APPE rotation, to help you be a better preceptor.
Yeah, I think students are surprised with how much non-teaching there is in being a professor or being a teacher. I think they forget that they were also advised by the professor, that the professor was on all these committees, that the professor has to prepare for, whatever. And when we think of maybe education, maybe we think too much of the lecture hall and speaking directly to the student, not thinking about, okay, well, we flipped the classroom, so now what do I give the student, and how do we make them learners within their own right? Well, let's look a little bit at Dr. Svensson. I thought I understand him as saying that the more clinical APPEs, the better, and that residency is the place to kind of pick up that paying it forward. So let's first get it right for you and then pay it forward. But what were your thoughts on Dr. Svensson?
I see where he's coming from. And one thing that I think is important to point out in his editorial is his personal experience, and kind of anecdotally, he's felt that pharmacy students that graduate are not yet practice ready. And on the basis of that, he argues that they just need more clinical experience and more rotations, and more is better, basically. Dr. Cox kind of comes back at him and says, more isn't always better, that quality is probably the more important metric than quantity. And I think that there's a lot of truth to that. I think myself included, I've heard of other students and even my own personal experience, not every rotation is going to be a stellar rotation. And I think that for those rotations that don't have high yield in terms of making you a better pharmacist or giving you a better feel for what you need to know as a practicing pharmacist, I think that, again, as a community, we need to think about how do we identify those rotations, how do we make them better, or how do we identify higher quality rotations to get us to that practice-ready standpoint.
On your, I want to say it was the last HelixTalk or maybe the one before it, you talked about, and I hate to say the word good student versus bad student, so let's say more motivated student versus a little bit less motivated student for your particular rotation. They might be a stellar motivated student, but you just happen to be a required rotation. Let's just say that you made them all clinical APPEs, what do you think that would do? That feels like it's very one-dimensional to me. But I think that no matter what, if you don't have a motivated student, I feel like it has to be up to the student to decide, yes, I'm going to put this much into it. And I think a student could get just as much out of having 2 electives as they could have getting no electives if they were well motivated. But what do you think about the student's role in all of this?
Oh, yeah. I mean, I totally agree with what you said. So motivation and self-discipline and self-directed learning, these are things that you can't force a student to have and typically can't even teach them. It's one of those qualities, honestly, that makes a great residency candidate is someone who does have those qualities. On many rotations, students can kind of get by and be able to pass and they'll do okay, but if they really want to get an excellent experience out of those rotations, they do have to have some degree of a self-directed approach of asking questions and having their own follow-up to the questions that they have, and seeking out projects and seeking out more information. That's super important to get the most out of a rotation, and typically a preceptor can't make a student do that. That has to be on the student's own initiative to do that.
There's something that always confused me a little bit, or maybe with the new guidelines, and correct me if I'm wrong, but my understanding is that you can have a 4-week, a 5-week, or a 6-week rotation, and you're allowed only 2 electives. But that means that you could have an 8-week versus a 12-week experience. You're talking about a month difference between any 2 colleges of pharmacy. Can you just talk about how your electives work, or how your elective system works at Rosalind Franklin, kind of maybe why you guys decided to use that particular experiential? I know that you are not in the experiential office, but what was your guys' rationale for the way that you set up the experiential part, which I think is, just one step from being a pharmacist?
Yeah, so, kind of to answer that, I kind of want to go back to my Butler days a little bit to give kind of a good comparison. So when I was at Butler, we had, I want to say it was about 10 4-week rotations. Okay. And I don't recall the balance of electives and not and things like that, but I had some awesome rotations, and I was able to have some of these awesome rotations simply because I had 10 of them and I had a lot to work with. Everything from an underserved Hispanic clinic where I was basically speaking Spanish all day to, time at Eli Lilly to see kind of the industry side of things. I had 2 different critical care rotations, which almost never happens. I really lucked out on that. So sure. I was just able to have, a wide variety of a lot of different cool experiences. So here at Rosalind Franklin, we actually have 6-week rotations. And we also have a system called a LAPI, a longitudinal APPE or APPE, which means that students will go to a health system like Advocate or Northwestern, and they will actually spend 4 of their 6-week blocks within that system. So Condell is an example where I work. They may do a hospital rotation, an admin rotation, transitions of care rotation, and then an ICU rotation, all in the same building, back to back to back to back. Clearly, the advantage to that is that you're not relearning an EHR every rotation. You kind of know the system, you know where to park, you know everything about the site. And from the site's point of view, they don't have to train new people every month because they have these people who kind of know what's going on. when the LAPI system first rolled out here at the university, I was very opposed to it. Based on my experience at Butler, I loved the fact that it had such a rich diversity of experiences. But now that we've had a couple LAPIs under our belt, I really can, as a preceptor, see the value in it. And I can see students being able to pick up the clinical skills quicker because they're not struggling through the EHR and things like that. So
taking the administrative component out of it in many.
Absolutely.
So that kind of frustrating time, that first day, isn't really a first day.
Right.
In the sense of, okay, I didn't know we had a student this month, and that doesn't happen that often, but just kind of getting to the point that sometimes preceptors are like, oh my gosh, that's right, we have a student, I forgot it was this day, now we've got to get you up to speed and how
get you a login.
Yeah, how can we get all this and make it meaningful quickly? And I'm not from Chicago, I'm from Baltimore, and I know how big Baltimore is. Can you explain where Rosalind Franklin is? Because my understanding is it's in North Chicago, and Chicago is so big that means 20 to 25 minutes, which to me, I didn't know. I just thought Chicago was just this, here's Chicago, and here's not Chicago.
Right. It's kind of funny. So like North Chicago, the word North Chicago is actually the city that we're in. So it's not like the north part of Chicago. It's literally North Chicago is the name of the city. Okay. And we're actually probably closer to Wisconsin than we are to downtown Chicago. So we're very far north. Which is kind of good for our students because that means that students that are kind of up in the area have the opportunity to go to a place like Milwaukee, and it's not terribly far away. And they can also go downtown, and it's still not terribly far away. So we have access to a lot of different kinds of practice sites at our disposal simply because of geography, that we're not strictly downtown and we're not strictly, all the way up in Wisconsin, something like that.
No, that makes a lot of sense. We were in Baltimore, but close enough to D.C. that we could have Washington, D.C. and Baltimore. So it sounds like something similar, except we were truly an urban campus. Well, I want to keep the podcast not too long, but how would somebody contact you if they did want some more information?
Yeah, so, our information is available at HelixTalk.com. We're on Twitter at HelixTalk. And if you're more interested in kind of the ClinCalc side, it's ClinCalc.com or at ClinCalc on Twitter.
Okay. And then just to give us some good advice, just a couple of quick hit questions here. What's your best daily ritual to keep your work on track? You're clearly a busy person, clearly a lot of responsibilities. How do you do it all?
So my number one thing that I do every time I get into work is I make a to-do list. And I probably spend like 10 or 15 minutes figuring out what things I have to accomplish, what things I'd like to accomplish, what are some of the longer term projects or goals. And then I have my cup of coffee. And I have to do both, otherwise it doesn't get off the right way.
Just that you do that afterwards, I have to confess, this was not my fault. The Dr. Oz episode was on, but he was talking about these 4 different types of sleepers, and that some people are supposed to have coffee after they get up, like an hour after they get up, and then some people at noon. So it's just funny to me that most people like, coffee, then I can think. Right. But it sounds like you think then you use your coffee as, a turbo boost or something like that.
There you go.
But, okay. But your best daily ritual is to spend 10 to 15 minutes
figuring out what I want to do that day. So, hours into my day, I know exactly what things I was thinking about that morning. It's just a way to stay organized and make sure you're triaging your time appropriately.
Okay, and I want to say that many students are looking to have your exact path, maybe not exact path geographically, but that they've gone to pharmacy school, they've gotten the critical care PGY1, they've gotten to stay in a city that they want to be in for their PGY2. What good career advice did you get to get you on that good road?
Well, first off, let's be honest. Some degree of luck has played a role in my ability to have the career path that I've had. Certainly part of it was, hard work and staying motivated and dedicated and things like that. I think that one thing that I'd emphasize to students, especially those who are more interested in leadership and entrepreneurship, maybe starting their own business or starting a new project, there's this thing called Imposter Syndrome. Tony, I don't know if you're familiar with this or not. It's the feeling that when you are trying to accomplish something or do something new or different, that you feel like certainly you're not qualified enough to do it, and then you get this self-doubt in your mind. Everything from ClinCalc to HelixTalk to a PGY1, PGY2, many of the things that I've done in life, if I listened to that imposter syndrome and let it take over, I would have never accomplished anything. So even if you feel like you're not quite there, aside from doing everything you can to get there, you have to acknowledge it. Almost everyone has a sense of imposter feeling or imposter syndrome. And if you let that take over, you're not going to do what you want to do in life. And it's important to acknowledge it, but also, pass it by on the road to success.
No, I've heard that, especially in PhDs, where you'll be around a lot of smart people who are very smart in their particular discipline. So when you listen to them, you're like, oh my gosh, I'll never get there. But where we really struggle with the imposter syndrome being in a community college is that maybe our student didn't do so well in high school, and they think that makes them necessarily a bad student now. And when I look on social and I look at YouTube videos, one of the number one questions I see students asking is, how hard is pharmacy school? And I think what they're asking is, am I going to get rejected? Am I an imposter? Am I somebody who, I don't have the perfect A's. I didn't do the 19 credits I'm supposed to do according to the rubric, on my college website. I didn't do everything perfectly. And my advice to them, like you say, is don't reject yourself. Let somebody else reject you and then move on to the next. But don't reject yourself from applying. Don't reject yourself from a profession, because you have evaluated yourself and in many ways, not the best judge. Let the admissions committee judge you, and let the admissions committee give you feedback, because that's the one thing that I think getting into pharmacy school, getting into professional school is much more about persistence than it is about perfection. But in their heads, it's more about perfection, and that's a great point you bring up. Well, last question, what inspires you?
For me, there's two things that inspire me. One, as an educator, to see the PGY or to see the P1 or P2 student progress through our curriculum, get to their P4 year, have them on rotations, and see them basically mature into this soon-to-be practicing pharmacist. And it's such a cool transition, especially in that fourth year, to see them move from student role into I'm going to take care of patients and do what's right for the patients. So that's one thing. The other thing that really gets me inspired and motivated is my clinical side. So in the ICU, making those great catches that dramatically improves patient care, whether it's avoiding an adverse effect or identifying, a medication that is missing that absolutely has to be there, or changing an antibiotic regimen to better cover a bug that ends up being this monster multi-drug resistant bug. All of these things in terms of improving patient care. That's the whole reason why I became a clinical pharmacist in the ICU, is to take better care of patients. So to have those big wins always gets me excited for the next day to go back into the ICU and do it again.
Well, it's clear you have so much joy and so much happiness with your profession and your role and the city that you're in. So again, thanks so much, Dr. Kane, for being on the Pharmacy Podcast.
Thank you so much.
Support for this episode comes from the audiobook Memorizing Pharmacology, a relaxed approach. With over 9,000 sales in the United States, United Kingdom, and Australia, it's the go-to resource to ease the pharmacology challenge. Available on Audible, iTunes, and Amazon.com, in print, ebook, and audiobook. Thank you for listening to the Pharmacy Leaders Podcast with your host, Tony Guerra. Be sure to share the show with the hashtag #PharmacyLeaders.